Hello, everyone, and thank you for joining us for episode 2 of the activity titled COVID-19 Impact on Caring for Your Patients with Gynecologic Malignancies. My name is Shannon Westin, and I'm an associate professor of the Department of Gynecologic Oncology and Reproductive Medicine in the Division of Surgery at the University of Texas MD Anderson Cancer Center. It's now my pleasure to introduce my esteemed colleagues joining me in the discussion today. Dr. Bhavana Pothuri, professor of the Department of OBGYN, NYU Langone Medical Center and Perlmutter Cancer Center, and NCI Designated Comprehensive Cancer Center. Hi, Dr. Pothuri.
Hi.
Dr. Ramez Eskander, associate professor, Division of Gynecologic Oncology at UC San Diego Moores Cancer Center. Welcome.
Thank you.
And Dr. Chirag Shah, Medical Director, Gynecologic Oncology and Pelvic Surgery at the Swedish Cancer Institute, and a clinical assistant professor in the Department of Obstetrics and Gynecology, University of Washington.
Hey.
Welcome. I'm glad to see everybody today. Last time we were, I know,
Nice
these are our faculty disclosures. I'll give you a second just to look at those. All right, so this webinar has been provided by BioAscend. BioAscend is an independent medical education company committed to supporting healthcare providers in their efforts to translate innovative science into clinical practice. All right, so first thing first, let's get a few questions from our attendees. We just like to get a sense of where you all are from and what you're doing. So the first question is, where do you practice medicine? Northwest, Southwest, Midwest, Southeast, or Northeast? And I think we're hopefully getting some answers here. Oh, here we go. Perfect. Poll in progress. We've got a really nice distribution here amongst our panelists. So we'll see what we have as far as for the attendees today. I think that COVID-19 seems like it's really not going anywhere, guys. What do you all think? I think that we're going to be talking about this for years.
I would definitely agree. I think this discussion has changed so much just even the past few months. It'll, I think it's going to stay with us. I totally agree.
Okay, so this is interesting, Southwest and Midwest. We, the last time we did this, we had a lot of Northeast. Isn't that right, Dr. Pothuri? I feel like we were looking at a lot of New Yorkers. That's my sense.
We definitely were, and this is a complete, I would say, switch, yes.
Yeah, okay, let's go to the next question here. All right. Maybe, okay, here we go. Are you aware of the COVID-19 positive inpatient census at your institution? A, no, I'm not sure, this is not shared. Yes, less than 10 beds. Yes, 10 to 25 beds. Yes, 51 to 100. Oh, and then 26 to 50, just to kind of mix it up there. What about you guys? How are your COVID numbers? I know we're going to have each of you talk, but are they up or down? We don't have to get into the numbers quite yet, but what's the trend looking like?
It's Bhavana, they're definitely down, and I think that's why you don't see any Northeasterners on this call.
Yeah.
Interesting. I think on the West Coast, we had a little bit of an uptick and plateau, actually. I mean, when you look at the numbers, but it hasn't changed as much as I thought it would, but there is a slight rise.
Yeah, we're down here as well. So.
Okay, so this is like a moderate number. So everybody that answered had 10 to 25 beds, and I think that's representative of who we're talking to today, the Midwest and the Southwest. All right, so let's see, let me get to our third question. Do you have ready access to personal protective equipment at your institution? Yes, gloves, gowns, N95 masks. Yes, but I'm worried we're gonna run out soon, sort of. Or no, we're limited or dwindling supplies, we're reusing masks. I would bet that we're looking pretty good with this group that's on today, based on the bed numbers that we saw, but let's see what the poll shows. How are you guys all doing with PPE now?
I have an interesting story. All of our PPE stayed pretty steady because, you know, they locked down surgery and everything pretty early here in Washington. But yesterday, all the surgical caps were on lockdown. So they were pulled out of the locker rooms and the places that they usually aren't. Apparently they had only like 3 boxes of surgical caps left for the whole OR. So
Wow.
yeah, it's just of all the things to be missing, it was just random.
That's kind of random. Yeah. Okay. So everyone's feeling pretty good. Everyone on the poll is feeling pretty good about their access. So 100%. That's good. That's good news. I think that hopefully we've learned, you know, from some of the earlier areas like New York, and I think people are prepared. Okay. Very cool. Let's see. I'm trying to move through here. Okay, so let's talk a little bit just about what's going on in the United States. I think that and really across the world, I put both sets of numbers here for our reference, just so we can see these numbers from previously, or when we had our last COVID discussion, which was I think around May 13th, 14th, if I'm not mistaken. And we were looking at over 4 million, and now we're above 7 million confirmed cases and over 400,000 deaths. And the U.S. is still leading the charge, unfortunately, with the number of cases, although Brazil and India are making a play to take over. Their curves are really impressively going kind of straight up. And these are just reported cases per day. The top, again, is when we met back in May. The bottom is where we are now. And, you know, back in May, we were saying, okay, it's looking good. We're kind of starting to flatten the curve here. But unfortunately, I think there are many states, including my own, that have completely basically reopened for business. And now we're starting to see another uptick in the overall cases reported in the United States. And I like this. This is a new graph I found, which I think is really cool, that kind of shows all of the different pertinent numbers. You can see that our deaths, definitely the daily death toll has gone down markedly, which is great. But the positive cases are starting to tick back up. We have increased testing, although arguably not probably enough for where we need to be. But as we have increased testing, we've been able to do more asymptomatic testing. So we are seeing an overall reduction in those test positive rates. So that's good. Oops. Okay, so here are the Texas case counts. And again, I've got my data from May and my data from now, and we've doubled our cases, unfortunately, or essentially doubled our cases. The death rate is staying fairly low, which is reassuring. But we are seeing, you know, still continued uptick. Harris County, my county in Houston, is leading, unfortunately, the number of cases, and a lot of that is just due to we're kind of definitely a tighter packed county than some of the other counties in Texas. And we have seen really an increase in our numbers. Our hospitalization numbers are back as high as they ever were. Unfortunately, over the last 3 days, we've had more hospitalized patients for COVID than we had even in our first bump. And that's across all of Texas, and it is also being reflected at the county level. And I think I have, yeah, this is our county, greater Houston area. You can see we're having an uptick in daily positive cases, in hospitalizations, and we are approaching into a kind of a yellow warning zone where if we keep at this rate, it'll be anywhere, it's gone back and forth over the last 2 days based on the case counts, but it'll be anywhere from 2 to 5 weeks till we're maxed out on ICUs. So unfortunately, we were flattening at the time of our last discussion, but we did have a really, I think, early opening back up. You know, we've got everything's open again, theme parks, you know, anything you can think of, and restaurants are at 75% capacity now. So I think we're seeing a reflection in that with the uptick in the cases. So I think, you know, for me, I think that we knew it was too early, but unfortunately the task force that was involved with kind of deciding when to reopen Texas really didn't involve many medical professionals. There were a lot of business people and the like. So this is what's expected if we open up too early. And I don't know, I'd be interested to hear when you all kind of talk through your numbers, but I mean, I go out in Houston very infrequently. I go to work, I walk my dogs. People are not wearing masks. It's like, it's over. In Memorial Day, we saw pictures of people that were just like packed together on the beach. And so I'm not surprised to see these numbers, because now we're seeing that bump from after Memorial Day.
Are there any measures to tighten up control again, like go back to a more restrictive, environment?
To date, I haven't heard anything. I think, the governor is basically putting it at the county level. Our county is still technically in a, stay home, work safe, but they really don't have an ability to kind of, to make that happen, because it's not in line with the governor. So it's not like they can, pull someone over and say, put your mask on, so it puts them in a little, like, they're suggesting it, like, please don't, please don't make your workers come in, please wear a mask if you're out there. But, people are hearing from a, higher level, well, it's fine. We can go to the salon, we can go to a theme park, we can go to the beach. So I think it's really hard, because I do think that Harris County did really a great job early on, and they shut things down very early. But then when we started having upper levels of government say, well, no, it's fine, go ahead. That's when we started, it's too confusing, and the average person doesn't know what to believe. You do your best as a medical professional to try to get stuff like this out here, make people aware, but it doesn't always translate, because, like, well, why would the governor allow the restaurants to be open if it wasn't safe? It's probably fine. I mean, there's a perfect example. Mike, we decided my kids aren't going to go on any summer camps. And that's just a personal decision we've made. We were like, it's too much. We both work in a cancer hospital. We can't get, we can't have any extra forms of exposure. And my littlest daughter is in a Montessori school, and they're a great school, so careful, and they followed the work, the careful opening, and they already have a positive case.
Yeah.
I mean, this is, and they did everything right. They did everything right. And so that's just what we're going to see.
Right.
Yeah.
All right, so let's talk a little bit about y'all. I want to get into where you all are. So Dr. Pothuri, you want to talk about New York a little bit?
Yeah, so, again, I did the same thing. I left the numbers from last month to now. So I'm happy to say that in New York State, we only had 50,000 cases in the last month. And this was probably from March 17th through May 12th was the initial numbers. And then 25,000 of those were in New York City. And you can also see the number of deaths have also stabilized. So our hospital is still in the level 3 surge space, but I think these numbers are really encouraging. Next slide.
This thing is real tenuous.
Really finicky, yeah. And then and then this is also, the number of people that we've tested in New York State. And you can see we've tested about over 2.5 million people and about 380,000. So that's about 14.5% that have now tested positive in New York State. And what's nice here is you can see in the yellow, the number of tested positive is really dwindling, which is really wonderful to see. And also the number that are being tested is increasing, which is also really important. And because of all this, there were 2 counties that have now opened in New York State. The Mid-Hudson County opened is actually open for phase 2 yesterday, and Long Island County is opening phase 2 today, and New York City, yay, finally opened on Monday, phase 1, and that includes elective surgeries. So that's really, has been a huge win. And I think it's kudos to everyone in New York who has been really careful. Like there are very few people I see on the streets without a mask. And people have been very diligent about even in the protests, like people have been masked, and so I think just heeding to all of that has been really, really great. So New Yorkers have definitely really buckled down, stayed put, and done the right thing, and we are now reaping those benefits. And I do worry with, while the social upheaval and the need to protest is real and important, and my heart 100% agrees with it, but my, medical cap is, really, really frightened, I will be honest with you, because I don't know what we're going to see in the next 2 weeks.
I'm concerned about that. It was amazing. Like Houston, there was something like almost 100,000 people marched, which Houston's not a marching type of city. They get out there, but this was so incredibly impressive. But you saw people were like wearing their masks down here, or not wearing masks at all, or it just. I completely agree. We absolutely need to be marching, and we need to be enacting change right now. But I'm also extremely concerned about what that's going to mean for the pandemic.
Right. And so, so anyway, these numbers are really reassuring, and we're very happy about them. Next slide. So, it's really, this slide is just, really shows you the ethnic and racial disparity here. So if you look at the number of cases, they're greatest in the Bronx, in Brooklyn, and in Queens. And looking at fatalities, you can see here that in New York City, while Hispanics only represent 29% of the population, they represent 34% of the deaths. Blacks represent 22% of the population, and they represent 28% of the deaths. And when you look at these age-adjusted mortalities, it's even more frightening. So this is real, and New York City obviously is a perfect example of all the diversity, so it's very glaring. Next slide. So this is just a busy slide, but again, I just wanted to point out that, it does show a reduced number. So this was May 11th, this is June 7th, and really a reduced number in terms of our acute care beds, our ICU beds. And so all the numbers you can see here have really diminished. Next slide. And then this is just showing it, in a nice picture. And you can see the total occupied beds really come down nicely. The total intubations, again, come down really beautifully. And even patients that have now been downgraded from ICU, all decreasing. Next slide. And inpatient discharges, we have less patients in the hospital, so that's good. Mortalities decreasing, also good. And the televisits appear to have stayed stable. So, this is clearly something that's I'm sure everyone is seeing, and looks like it's here to stay.
Well, I think, it's such an inspiring, there's such inspiring numbers, because when I was putting mine together, I was starting to feel a little bit depressed. So thank you. It looks, and you brought up the point, the people wearing their masks and really being serious about it. I think that's part of the problem with some of these other areas, like my area, which maybe hasn't had as big of a surge, is that people were like, okay, no big deal, we're done. We're over this. It's fine. It's going to be fine. So they don't, they aren't kind of using those same things. All right, Dr. Shah, why don't you take us through your numbers?
Sure. So, as I mentioned the last time we were all together, Washington State, first reported case of COVID, first reported death. Our total cases actually, so over whatever, I think 3-week period of time that we talked last, it went from about 17,000 to 24,000. So as we'll see, as we're kind of going through, and it's interesting when you look at the geographic distribution, cases, especially in the western part of the state, which is the more populated part of the state, have dropped. We're really seeing the new cases in the state these days. Actually, if you, I won't go too much further into this slide. If you can go to the next slide, please. Where we see this, the curve certainly on the top left in the blue there, with confirmed case counts, actually, when you look at that as a breakdown in King County, it's actually significantly flattened. A lot of the more recent curve is in the central, eastern, more rural part of the states. We've had a big outbreak with farm workers and food processing in the more rural parts of the states. But hospitalizations are down. The uptick that we see in the yellow bars, kind of more as in the later part of May and early June, is again in those same parts of the states. But most importantly, the death rates have dramatically dropped down since March and April. So I think this mirrors a little bit what Dr. Pothuri was discussing. Just so King County, where we're at in Seattle. Actually, if you can go to the next slide, please. These were the established metrics by the state, and I think I found these really kind of fascinating as I was, looking at this, and these are being applied to all the different areas. I know there's a lot of stuff on here, but the metrics are basically a combination of what's going on in the number of cases, what's going on with the outbreak. The green indicators are the ones that, for example, in King County, we were meeting, and as we're kind of in a similar boat to New York. We just got to phase 1 about a week ago. The restaurants just this past weekend opened up at 25% capacity, 50% outdoor seating, but a lot of the other parts of the state are already in their, in their phase 2. But it'll be interesting to see what happens. I think obviously the civil unrest that's going on within the country is, was front and center here as well. And we're not as populous as some of, the other cities that my colleagues live in, and what that's going to mean. But I was kind of shocked to hear, Dr. Westin, the idea that you guys are that close to being maxed out on ICU beds and stuff again, because, we're well within the metrics for hospital, our current, within our 5 hospital system, I think the total inpatient cases is less than 10 right now. So, there's plenty of capacity, at least up here for now. But, I think the one thing that I mentioned on our previous time that we're together is, beyond the state government's been pretty cautious, but the people of Western Washington have been more cautious than you certainly see a little clusters of people getting together, but it's not anything like what you see in the news and what's happening in other places. It's people are really keeping the distance, people still have masks on, those kinds of things. So
that's really reassuring. I'm hopeful that what will happen here in Texas is that maybe we'll see a little bump and people will realize, okay, it's been too much too soon, and back off a little bit. But I think only time will tell. There was a report yesterday that 5 or 6 restaurants that had previously gotten almost, to the 75% capacity have all had to close because of positive cases. So, I think those kind of cautionary tales may help, with kind of getting people to kind of hit a new normal and maybe not.
I have a quick question. I'm curious, just while we're on the subject, because it's not really reflected in those slides, but I'm wondering what level of contact tracing is happening in the respective states. We always talk about it, but I'm not really, I don't think there's anything firmly established in Washington, but I don't know if it's happening elsewhere.
Not much for us. Yeah. I know there's talk of it, and there was talk of hiring, but I haven't heard anything beyond that. And I certainly, haven't heard of any kind of established measures around some of these known outbreaks.
Yeah.
Yeah, same here.
No, we haven't had anything either here, definitive.
I think we know it needs to happen, but I don't know that it's actually happening. Okay, Ramez, you want to close us out on this one?
Yeah. So thank you, Dr. Westin, Dr. Shah, Dr. Pothuri. So California is an interesting state. I think it echoes a lot of the comments that were already made about reopening and what the implications are. But if you look, it's actually, although the overall numbers are low, the trend is a provocative trend, and that the total number of cases has essentially doubled from the last time that we met and had a discussion. It went from 66,000 to 128,000. And if you look at the fatalities, they have almost nearly doubled, 2,700 to 4,600. So again, the absolute numbers of cases compared to some of the really affected states on the East Coast are lower, but the trend that we're seeing is certainly a provocative trend, an interesting trend in some ways, and also speaks to some of the uncertainties around reopening and the implications of reopening, and obviously what we alluded to and discussed earlier, the justified protests, but what are the implications of people being out and about? And to some degree, people just, like you were mentioning, Shannon, they're just, a lot of people I hear socially, I'm tired of being at home. Yeah. I don't want to be cooped up anymore. It's time to go out. If I get it, I get it. I mean, just the nature, the dialogue is now evolved from, okay, we're going to stay at home, to I got to get out of this house and I'm going to go out and about and do the things I need to do. And it's interesting what you mentioned, Bhavana, that in New York, a lot of people are masked and there's a lot more responsibility. In California, it's not the same thing. Some stores mandate that you're masked. Other stores, just if you come in with a mask, fine. If you don't, they don't stop you. And socially, not very many people wear masks when they're out and about, walking their dogs out in the streets. I haven't seen it. Now, granted, I haven't been to, a a mall or anything like that to see what it was like in those locations. I'm just talking about who I see socially, walking outside, interacting in the public space. If you can go to the next slide, Dr. Westin, please. And here, I want to just mention the San Diego data. And again, if you look at the San Diego statistics and you take a look, in the last 14 days, 1,775 new cases, 37 new deaths, tests reported 38,450, and the number of positive cases has also expanded and grown. I do want to bring back a really interesting point, because if you look at the impact of ethnicity on case numbers in the state of California, it's actually quite a dramatic difference. 56%, essentially 55.5% are Latino. The next is 18.5% white, and then 4.8% black, and Asians is 8.2%. So there's really a dramatic impact in the Latino population in California in terms of the burden of COVID-19. If you go to the next slide, please. And here, I'll show you the data from our institution. What was interesting and a bit concerning to us is, if you look, this yellow is ventilated COVID-19 patients. And the blue above it's not. And you can see that we had a really pretty quick uptake in the number of admitted and ventilated patients that's now come down. But if you look at our total number of patients based on in-house census, it's been pretty flat. There's really not been a dramatic trend over the month that we've talked about. But this map, a heat map on the right, shows you that the number of cases, this is on the bottom right hand of this image is Imperial County, which borders Mexico and Tijuana. There's a lot of expats who actually live in this area or live across the border. And there was a significant increase in the number of cases, and that's grown actually quite dramatically over the last 4 weeks. And those patients are then coming across the border. Those hospitals have limited resources, and so those patients get admitted and then subsequently transferred directly to our institution. So the increase in the ventilated admitted patients and the increase in the total number of patients is related, we think, directly to the number of cases that are on the border and what happened in Tijuana. And we actually had several pulmonologists, ICU doctors who went to Mexico with nurses to try to help kind of bolster their response, to give them the resources needed to care for the patients there to prevent an influx across the border. That's it.
Perfect. Well, that's a really great discussion. I think now we'll transition a little bit into how it's a current COVID, the pandemic is currently affecting, I don't know what's going on over here, how we're practicing, especially taking care of patients with gynecologic malignancies. I think before we get into the specific types, I was just curious to see what's going on with testing for you all in your institutions for patients. So, are you testing anybody that walks through the door, or are there certain things that you're testing? Just give me a sense of how much testing you guys are able to do now in our current state.
It's an excellent question. I think we'll all have, I anticipate a similar answer, but we are testing everyone who's admitted through the emergency room or a scheduled admission or a planned surgery. All are tested. We are also testing all of our patients who are receiving chemotherapy in the infusion centers, both before they start treatment and every 2 to 3 months while they are on treatment, or sooner if they have an exposure. Interestingly, and I think this is an important piece of information, we've tested over 4,000 healthcare employees, and we've had one asymptomatic positive. So the reason I think that's relevant is because it shows that the transmission is not happening, we don't think, in the hospital setting. The exposure risks are low, both in the infusion center and in the hospital, which is reassuring, I think, to patients. It's community spread predominantly, but we are testing everybody.
Great. Dr. Shah?
So we're, I'd say pretty much echo what Dr. Eskander said, except we're still, it's interesting, we talked about this last time, we still haven't gotten to the point where we're testing all of our oncology infusion patients. There's been bandied about how to handle that, but it hasn't really reached a policy. But all the inpatients, all the surgeries, there was an interesting, up till now, there was a pretty flexible policy in terms of if patients didn't get tested and then they were asymptomatic, but the one newest little wrinkle is any long-term facility patient that's coming in, if they don't get tested, their surgeries get canceled. So they're, you know, at least recognizing that that's a very high risk group. So that's maybe just only a recent change for us.
Great.
Yeah, for us, I would echo any inpatient, anybody receiving a procedure, you know, they're all getting tested, even, you know, whether it be a radiologic procedure, IR procedure, surgery. The thing that's changed was prior, we weren't testing all patients getting chemotherapy. We were only testing patients who were either had a hematologic malignancy or had we're starting immunotherapy, and now we're testing all our cancer patients who are starting treatment. We haven't gotten to the point where we're testing them at intervals yet, as Dr. Eskander said, but so I think that's a step for us.
It sounds like everyone's kind of heading in the same direction. You know, at Anderson, we have a huge population of people that come from outside our general area. And so we're testing all new patients. So anybody that's new to the institution, and they're using that not only obviously for risk, but also they're keeping track of different areas. And so if they see certain areas that lots of patients are coming in positive, then maybe they'll, you know, make sure we use certain types of precautions around that. We're testing we're not doing any infusion patients yet. They're doing the stem cell patients and some of the leukemia regimens, but we're not doing necessarily everybody that's getting infused. And I think a lot of that is because we're testing all the new patients instead. And then we're testing surgical patients like all of you in admission. So I think that there's a lot of similarities here. And I do think that the availability of testing seems to be improving in all of our institutions, which is, I think, is very reassuring. Are you guys running them in-house? Is everybody running them in-house? Yeah, that's same here. And we're actually, I think our institution's doing a little bit of testing for the state too, which I think is great that they have been able to get some of the bandwidth to be able to do that. So what I want to do over the next few minutes is just kind of touch briefly. We had these same slides last time looking at how we are treating ovarian cancer, endometrial cancer, cervical cancer in the midst of this global pandemic. And I want you guys to touch on some of the pieces that you did before, but also how those things might be changing, or, you know, if we're really going to be doing this for the next, I mean, some of the epidemiologists are saying 18 to 24 months. You know, is it going to be that we have these increasing restrictions at times and then back down again? And, you know, what do you guys think, and how is that going to affect the treatment and also diagnosis, right, of our patients with these cancers? So I think we're going to start with Dr. Pothuri and ovarian cancer.
Yeah, so, you know, we put out recommendations for things to consider in terms of neoadjuvant chemotherapy for ovarian cancer patients in lieu of primary surgical debulking to reduce morbidity and risk of hospitalization over primary surgical debulking, especially in high COVID-19 burden areas. I think now we're able to offer surgical primary debulking. The one issue still has been the blood. You know, there is a blood shortage. Yeah. So, you know, these patients tend to, need those resources. So I think just keeping that in mind is important. And then, you know, delaying interval surgery if needed beyond the 3 to 4 cycles of neoadjuvant chemotherapy. And as, you know, we've been fortunate to really move into a situation where we now are able to even do surgery that is elective. I think we don't necessarily need to utilize this consideration as much, but clearly if, you know, there are other areas that are getting into these states where they are going to be highly COVID burdened, and these are considerations that one can consider. And then we're still doing this, you know, choosing regimens that necessitate the fewest infusion visits. So the Q3 week paclitaxel carbo, avoiding those weekly, you know, Taxol regimens, you know, and avoiding the more complicated chemotherapy regimens like IP and HIPEC. And in terms of maintenance, you know, I think, again, I think we have been able to continue maintenance even during, you know, we did at one point limit the use of IV maintenance therapy during the peak of the pandemic. But in terms of the oral maintenance therapy, we were able to continue it with televisits, and actually I'm continuing to do that even now. You know, patients are still happy to do their labs locally when needed, and you know, utilize the televisit platform and continue their oral maintenance therapy.
Great. And then I think we have a little bit on recurrence.
Yeah. And in terms of recurrence, you know, some of the recommendations were to consider delaying the start of new therapy for patients with asymptomatic recurrence or CA-125 only recurrence. And again, I think, you know, now that we've moved beyond the surge, I think we are more comfortable starting some of these patients and having more of a shared discussion with these patients about what their goals are, and you know, the risk of coming into the infusion center and getting therapy and the benefit. And that goes true for, you know, all of these considerations. Here, you know, for patients with symptomatic recurrent disease, the choice of therapy should be predicated on minimizing the exposure to other contacts, risk of therapy, and life expectancy and prognosis, considering lowering the lower dose intensity, like we talked about in the upfront setting, and less myelosuppressive regimens. We're still definitely considering all these very seriously. And, you know, this, the whole role of lymphopenia and neutropenia was really unclear in the beginning, but I think now we have some newer studies and larger studies as opposed to the original data that just came out of Wuhan, where there has been, you know, there were 2 series that were recently published in the Lancet. You know, one that was a retrospective cohort that included the United States, Canada, and Spain, and they found, and that was about 900 patients, and they found no difference in terms of anti-cancer therapy, recent surgery, and they did not find that it was associated with mortality. And then there was another, actually prospective cohort study out of the UK that looked at about 800 patients, and they found the same thing, that they couldn't find any factors, you know, that in terms of cytotoxic chemotherapy, surgery, or other anti-cancer therapy that increased the mortality from COVID-19 disease. So I think having that information has definitely helped all us counsel our patients better and feel more comfortable. And I think in the very beginning, you know, we didn't have all this information. So I think we had to be very cautious when we put out these considerations. But I think as more knowledge and data is evolving, I think we can, you know, better counsel our patients and feel more comfortable offering these therapies to patients, even in the midst of the pandemic. And as you said, I think the pandemic is, you know, is expected to continue until 2022. And I think this data is really important because it highlights that we can continue to safely offer critical cancer therapies, and, you know, and that's going to impact their overall outcome. And patients shouldn't be scared, but neither should physicians. You know, we need to get our patients back in. They need to get treated, and they need to understand these treatments are safe.
You know, I think you brought up several great points, and I think the telehealth point is a big one. I think many of us are doing so much more. We never did telehealth. I mean, we would call patients occasionally, but having organized telehealth on our schedule, and I think it really does help with the social distancing, like limiting the number of people that are in your waiting room, you know, limiting the number of people that are required to be in the clinic to get patients in and out, you know, nurses and MAs. And I think all of those things are going to make a difference. And so having that those long-term strategies in place as we kind of face this is going to be really important. So we just want to get you guys back at some ideas about how things are changing now with your management of advanced ovarian cancer. So, and I would just say, not necessarily during the entire pandemic, but where are you right now? Are you, you know, in your strategy, are you using more neoadjuvant chemotherapy over the primary debulking? You've always been using neoadjuvant. No, you've always performed surgical debulking, or you're just using your normal strategies right now to decide whether or not you're performing surgery or adjuvant therapy. I mean, I think, you know, for us, there was a concern, you know, that we should be doing more neoadjuvant, but as we've been able to do kind of surgery as needed, now we're back to our normal strategies cautiously. I think we're all watching the numbers in Harris County and keeping an eye out. And yeah, we had a huge issue with blood shortages last week that actually some surgeries had to get canceled, and based on blood type, which was really eye-opening. And so there's been a lot of pushes for employee blood drives and things like that, so that, you know, those types of issues don't limit, you know, the types of surgery that we're able to do. Let's see our results. Okay, so yeah, so this, again, this is a group of Midwesterners and Southwesterners, and they are still using their normal strategies to choose surgery versus neoadjuvant. All right, so we'll move forward. I think we've got one more question here. Wait for it. What about maintenance therapy? Has, where you are currently with the COVID-19 pandemic, has that changed your use of maintenance therapy? And I think that Dr. Pothuri mentioned this, you know, trying to avoid IV maintenance at some points. So here we're saying, I never use maintenance therapy, which, gosh, if we're talking upfront, I hope that we're moving away from that, people. We're continuing per prior practice. We stopped. We're using more PARP instead of bevacizumab, or we're using more bevacizumab instead of PARP. What about you guys? Are you, I know that, you know, for us, we're kind of proceeding as normal.
Yeah, same here.
You know, I think that, oh, yep, per prior practice. And I mean, I think this is consistent. I think right now we're in a little bit of a kind of a waiting period to see, you know, what's going to happen with this next surge. I think that, for people in, you know, academic institutions, I think that that things are proceeding. You know, I think in community practice, it's even better. Like, we're personally sending out our patients to get their infusions in our community centers to, again, avoid the kind of hectic or high levels of patients all at one place in the medical center. And I think that's been really helpful. Okay, let's do a little review of endometrial cancer and how the pandemic might be affecting that.
So, you know, I think since the last time we had this conversation, I think it seems like pretty much everyone on the panel is doing elective procedures. I think so. You know, I think in the world of elective surgeries being allowed, there's, you know, certainly not any restrictions in terms of any grading for endometrial cancers. That's been business as usual for us. But you know, for those places that are either where the healthcare system is taxed or resources are of short supply, you know, certainly one option is to treat the low grade or EIN CH patients with hormonal therapy. You know, the preservation of PPE, thankfully for us, really, even though elective surgeries were canceled, was a pretty short interval. We were back to doing cancer operations within a few short weeks of the initial statewide shutdown. So I don't think anything else to add there. We can go on to the next slide. This is the modified elective surgery acuity scale, and you can just put up both the little bubbles that are there. That should come next on the next click. Sorry.
Okay.
Okay.
Yeah.
So we have basically, you know, our tiers here. So in the situation where you know, you have a low or no COVID census, you know, basically business as usual, which we've seen a fair bit of just in our audience response questions, at least with this audience, that people are getting back. I think, as Dr. Eskander voiced, you know, I've definitely heard that too, you know, when I think about it socially and with colleagues also, you know, if we're talking about it, you know, everyone else is too, just this idea of getting back to normal. But I think with medical practice, that kind of applies too. I think all of us understanding, you know, I think there was a slide that we passed through this whole concept of this new normal. I think, you know, walking around the hospital all day with the mask on is just it feels normal now. Now it actually feels weird to not have one on. So you know, I think that's kind of where we're at. So there's, I think, one more little bubble there basically. And this was the case, even if you're in you know, a high outbreak situation, or we hit this second wave and numbers really spike. I think one thing that we really learned is that, you know, you have to keep treating your cancers if you can. You know, I think, you know, it's I don't know what the others in the audience have seen. We've seen some pretty striking morbidity from patients who either had delays in diagnosis or, you know, I've been surprised by how much there is. Again, this is all anecdotal as opposed to published study. It'll be interesting to see as the data unfolds. We collect this information from what's happening with our cancer patients that either had a delay, but that just in my own practice I've seen it. So I think whenever we hit at various places, it seems like it's already happening, like it's happening in Texas for you, Dr. Westin. But whenever we hit these second waves, we want to try to keep treating our patients and their cancers as we can. So.
Yeah, I know I'd say for Anderson, we're cautiously kind of opening things up, understanding that right now our personal census is low, and hopefully it will, our institutional census is low, so hopefully it will stay that way and we can continue to keep taking in the cancer patients and caring for them. But we obviously have to be ready to kind of back things down as needed if PPE becomes an issue, or if the outside in the Texas Medical Center the numbers are increasing. One thing relevant to both endometrial and cervical cancer is the pembrolizumab, use of pembrolizumab. So I think that all of you are aware of the recent FDA approval for every 6 weeks instead of every 3. Have you thought about that? Have you used that? Have you transitioned some of your patients to that new regimen?
I've been using it on all my patients, and it's been good because it does limit that one visit for them. I have noticed a few more AEs related to giving the higher dose. A lot more like myalgias and fatigue initially, but they seem to get over that. So but I have been utilizing that pretty judiciously. So yeah.
It's funny you bring it up. I've talked to a few patients about it, and ironically, they're responding to their Q3 week, and they looked at me and they said, I don't want to change because I'm doing okay on my Q3 week regimen. And because just like you mentioned, Dr. Pothuri, I said, well, I'm not exactly sure whether or not your side effect profile is going to be the same. And they look at me when I say that and say, nope, don't rock the boat. I'm fine. I'll come in. I'll see you every 3 weeks. And it's funny how many of our patients are like that. They're doing well. They don't want to change anything.
It's a great example of your shared medical decision making. I love it.
That's exactly it. Or superstition, or both. I think what we learned, and it echoes a lot of the comments made earlier, the benefit of what we went through is that it showed us that number one, we could have these interventions in place institutionally that will allow us to continue to care for our cancer patients, even if we get another wave or a third wave. And when this first started, we didn't have universal testing. We didn't have universal masking. Our hospitals were trying to figure out what to do. One week we'd get one email, the next day it would be another email. So I'm optimistic in that even if we do see an uptick in cases, because we have the infrastructure in place for testing, for patient call lines, for how they get triaged, hopefully it won't interrupt cancer services and cancer care in a way that we were concerned about initially. So for cervical cancer, initially there was discussion about avoiding radiation if possible. Obviously, radiation is daily visits with radiation treatment for our cervical cancer patients, and that can have exposures. Our radiation oncology services for cervix and all other solid tumors was never interrupted during the COVID pandemic. They continued uninterrupted, but they just instituted, no visitor policies, universal testing, masking, etc. But initially, when there was concern nationally about where patients were receiving their care and what the institutions would have available to them or at their disposal, the thought was if you didn't need to initiate radiation immediately, you could potentially defer it. For stage 4 cervical cancer patients, consider delaying or deferring palliative therapy, particularly if patients are older or have significant comorbidities. And then early goals of care conversation, which again, we talked about this in our last webinar. This is important, COVID or not, in this patient population, so that they're aware of what their prognosis is and what goals of care are, which is really foundational when you're talking about their treatment. Next slide, please. And here, our gynecology/colposcopy clinic that does a lot of the triaging for cervical dysplasia was initially staggering their visits and pushing them out per the ASCCP guidelines on March 19th. But again, in the context of now, we're stage 2, our hospital's completely open to all. It's kind of strange. I went from operating and there was very little to nobody in the operating room and it was easy to get cases on, to now everything is back at full effect. The orthopods are operating, everyone's doing their elective surgeries, the hernias, etc. And now everyone's competing over OR time once again. So there's really not a delay in terms of managing dysplasia anymore. The colposcopy clinic is up and running, it's staffed the same way, with an ability to pivot if need be based on future demands or requirements. Next slide, there we go.
Well, before we go to this question, I wanted to touch on something that you spoke about, radiation, which I hadn't mentioned. The daily visits really are a kicker, and we did have a couple of instances of positivity in patients that were receiving radiation, and there was a big concern about the contact tracing because there's so many people that are involved in kind of getting that planning done. So we are, we're testing all our patients at their start of radiation, and then they're kind of, I think, intermittently testing them as well. But you're right, you don't want to defer definitive management here. So last question for our audience, and we can continue our conversation, is clinical trials. So, how have clinical trials been impacted? And again, maybe, how have things changed? Are we back to normal now? There's no change, or we've had some changes to conduct, or things are halted. What about you guys? I know we're kind of ramping back up. We are doing a lot of telehealth, but we had previously closed a lot of trials or at least paused them. But now we're up and running and opening even new trials.
We're the same. We're reopening. Initially, we started with like our highest priority. Each disease group, management group, was asked to pick, a few high priority trials to open, and now all our trials are open.
Yeah.
And we are also new trials. Yeah.
It's kind of pre-pandemic, basically, in terms of research for us at this point.
What about like research biopsies and things like that? Are you guys doing that completely?
Yeah, we've resumed those. We actually, the last thing to resume was the tissue collection protocols, biorepository, and that just actually, as of last week, is now reopened. So even that's a go at our institutions. That's
great. Our institution, one big piece of it for us is the lab-based research, and the labs were all, everybody was home. And so I think that they're starting to reorganize for next week to see when things are going. And I think we got our interesting.
Wow.
100% will have new enrollment halted and conduct affected. That's really interesting. And I think that goes back to what we were discussing around the group that's watching this right now, is that this is a group where I think it looks like people are like that Midwest, Southwest, where things are kind of picking up comparatively to some of the other cities. And so that is really interesting. I think it's reflective of kind of the way that this pandemic is going to move through the United States, and kind of we'll see these ups and downs. I think this has been a really interesting discussion. I wonder, we should do another one in like another month. It's just so interesting because at first when we talked about doing a second one, I thought, what are we going to talk about? I'm going to have to really kind of bring some stuff up. But, I really, it is very interesting to see kind of the changes over time. And I do think that we're going to see permanent changes in our practices. Don't you guys? I think, I think for us, telehealth, I don't see it going anywhere.
Did it go down? I know, Bhavana, you brought up the telehealth and showed the graph with a slight decline. For us, it peaked super rapidly, uptake, and then now there was, I guess, a lot of feedback from patients, the cancer patients, that they wanted to come in and provide it. So it very quickly, from 70-30, for example, or 75-25, 75 telehealth, 25 in person, it's now almost flipped back the opposite, where it's 75% in person, 25% telehealth. And I don't know if that's regional mostly or if it's patient driven, but I've gotten feedback both ways. For example, today I have clinic, I have 0 telehealth, all in-person visits. Wow. Tomorrow I have 1 telehealth, all in-person visits. So it really flipped. When we had this webinar in May, it was the opposite. It was almost everybody telehealth and 1 or 2 in-person visits. So I don't know how it's evolving in your institutions, but it was very interesting to me how quickly we kind of evolved to go back to in-person once these this wave kind of.
No, I think the great thing though is this kind of speaks to the point you were mentioning earlier, is now we're a little bit more nimble, you know, in the sense that if things uptick again, you know, you can quickly flip that switch back the other way. You know, I actually, our practice kind of mirrors what you're describing in San Diego, in the sense that it has gone back towards more, and I think because things have been, you know, pretty stable over here, but I could see a scenario where if there is, you know, an uptick in cases where, you know, we can now we have the tools. I mean, the first time through it was a little harder.
A lot harder, yeah.
Yeah, I think for us, I think, you know, I think it's going to stick, because I think in New York, people are busy. They don't want to come and wait, you know, they would be happy to just speak to their doctor, you know, and get what the care they need, as long as they don't need an exam. And we've learned that we don't necessarily need to examine all our patients, right? And, you know, the symptom check seems to be the most important. And if they can get local labs, it seems to be, you know, a pretty good way to deliver care. And the other thing is, you know, I do agree with you, Ramez, that some of my patients have said, "Oh, I need to get back and see you. It's not the same." You know,
Right.
I definitely had that, and you know, and they've come back to the office. But there are many that are, you know, really still liking the televisit platform. And, you know, even our institution is kind of, you know, we're still trying to do the social distancing even at work. So we're trying to do a day where we see patients and then a day where we do telehealth visits. So we try to keep providers and medical assistants and secretaries out of the office if we can. So, you know, our whole workflow has been kind of geared towards that mentality. So I think for us, you know, telehealth will probably still be here to stay for a little bit, you know, and I think even down the line.
You know, we have a similar situation. Plus, our practice, again, I have patients on clinical trials from all over the country. And so it's fantastic for them to be able to just see me by video and not have to, say, drive in from Arkansas, you know, for their weekly visits on their phase 1 trial. So I think for that situation, it's going to change. And they can say, and we always tell them, you got a video visit, but if you really feel like you want to come on in, just let us know and we'll flip that. And so we are transitioning to, you know, some in person, but especially with some of these other patients, that it's a boon for them not to have to travel. It's, you know, they're saving money, they don't have to take flights. And so I do think that, you know, depending the discussion around what the FDA will allow us to do, you know, post-pandemic, I think it will be interesting to see if we can do some of those weekly Cs. You know, I always call them well baby checks, you know, when you know the patient's doing fine, there's no symptom, you're like, okay, thanks for coming all the way over here for nothing, you know, and get your labs at home, you know. So I do think for us, it's been a real awesome opportunity to allow people to go on trials that maybe didn't have the ability to do it because of travel, would be limited from travel. You guys, I cannot believe it's been an hour. Thank you all so much. Thank you so much to my colleagues for this awesome discussion, and thank all of the listeners for joining us today. We hope that you've come away from this discussion with practical knowledge that you can apply to your practice. And visit bioascend.com/COVID-19 to view previous COVID-19 episodes on hematologic malignancies, GU cancers, lung cancer, and gynecologic malignancies. You can also find other educational offerings at bioascend.com. Thank you all, and have a great day.
Thank you.